Dear Chairman, dear colleague, my topic today is to find a solution to improve the building of a therapeutic strategy, and I am going to explain to you a tool that you use to classify your patient and to make the strategy. To establish a classification on a pathology is probably the best sign of the good knowledge of its different form and a good codification of the therapeutic strategy. It's probably for this reason, in case of upper neuron palsy, no surgical classification is clearly specified. Contrary to tetraplegic patients, there is no specific classification to grade spastic patients according to their neurological state. Probably in this population, it's impossible to identify a linear degree of severity. No classification allows us to build a codified therapeutic strategy, making each patient has a singular case. Unfortunately, often therapeutic strategy has to build essentially on the experience and the feeling of the team. The ideal classification for surgeon probably doesn't exist because this classification, such classification allows to precise the description of the different case and the different stage. The goal of this classification for the surgeon is to help to communicate with the other member of the team, for MPR notably. The other goal is to identify the problems that limit the function, aesthetic, nursing, this is another one. And another goal for the surgeon is to build the surgical strategy to identify the problem. The last objective of this classification is to evaluate the result and to make the follow-up of the patient. The form of such classification is very important to be easy to use every day, daily. A so too complex classification won't be used daily. You made some objectives. We want to this classification has to be quick to perform, easy, without need of tool. It's very important for surgeon. And the possibility to be used a posteriori according to the video. It's very important, and in your experience, we perform video in all the patients in pre and post-operative. This classification has to be sensible for sometimes the very little improvement of the function of the patient. And this classification has to be able to evaluate the transformation, the modification after the surgery. It's not necessary to evaluate something that the surgery are not able to transform or to modify. Surgery or toxin injection or test evaluation. Before to make this classification, we decided to identify some parameters that are important for us, and the first is to base this classification on analytic prognostic factor being potentially modified by surgery or other treatment like toxin or anesthetic block. The first parameter to build this classification is the quality of the positioning of the hand in the space, and especially the proximal function of the upper limb on the shoulder, elbow, and forearm. The second parameter is that to consider that the release is more important than the grasp, because without release, the hand is not used, and it's very important to identify this parameter. The third parameter is a vicious attitude. Unfortunately, the surgeon is more efficient on the correction of the vicious attitude than to restore some function. This parameter you can see on the classification is very important. And the last one, to be if you want the classification has to be sensitive, we have to consider that the best result is not a normal hand, but the best result is the hand who are be able to grasp and release or use a bimanual hand. This is relatively limited, but I think it's important to have a good score. In synthesis, our classification is based on 4 parameters. The first is the upper limb proximal function. I explained you after. The second and the third is a pronosupination. Pronosupination, active pronosupination, is very important to use a bimanual hand, and you can see as you consider this parameter. The third is a wrist extension, and in these 2 cases, the vicious attitude. We consider that a patient with a vicious attitude of the pronosupination of the wrist are not be able to use the hand to take, same in bimanual class. And the last factor is the thumb and the finger extension. In this case, we consider the vicious attitude with the hand while completely flexed. You can see the classification, and here the first parameter is the proximal function of the upper limb. You evaluate it by consider which part of the body the paralyzed hand can attain. For example, in the few cases, the navel, leg, breath, mouth, front, and in this evaluation, it's very important, and we grab the patient. The second parameter is the pronosupination. We consider active pronosupination is the best result, but we consider too the vicious attitude. There are some patients who have no pronosupination, but the hand is in hyperpronation or hypersupination and is a disaster functionally. The other parameter, this is the wrist extension, the finger extension, the thumb extension. But in all cases, we consider the vicious attitude first, after the active function, and when the active function in present, we consider the good active function easily, and the patient, we have to work a lot to extend the finger or extend the wrist. It's very important because in this last case, the hand the patient doesn't use the hand. The last factor is the vicious attitude of the thumb, because with the vicious attitude of the thumb, we have to appreciate the intrinsic spasticity, and this factor is very important. For us, the more important thing is the result. And it's interesting to see the correlation between the INOM score, or score, and the house score that the main score used for the prevention in the surgeon. And it's very exciting to see that in this population, we note a very good correlation between the house score and the INOM score. The second part is that when you consider the INOM score for different house score, it's very interesting to that in each group you find a very high similitude with this score. The second thing is, in this case, when you have a patient with a house 3 and you improve, for example, the INOM score for 20%, you apologize. No, you try to improve the house score, the INOM score for 20%. For example, with correct supination contracture or the flexed wrist. You are not sure, but you can esperate that you improve the house score and you improve the function. For each patient, it's possible to describe the situation with the proximal function, pronosupination, wrist extension, finger extension, thumb extension, and vicious attitude of the thumb. Each patient are classified with the radial diagram. There are some factors surgical independent, the proximal function, for example. It's not possible to modify this parameter, and you can see sometimes it's modified when you correct a vicious attitude. And there are surgical dependent factors that you can modify by your surgery. This classification is important because you can build your surgical strategy. In this case, you can see there are vicious attitude of the wrist. And with only wrist arthrodesis, for example, you improve the capacity of the wrist. In this case, it's possible to see where is the problem. This problem is the wrist. There are a deficit of finger and thumb extension. And with this one, it's possible to build the strategy, the surgical, or the strategy of the injection of toxin, for example. You can use the score on the follow-up of the patient. You can see the first time you see your patient in the consultation, you make the first score for the evaluation. You see the problem, and it's be possible to build the surgical strategy. You see what you want to perform. It's possible to test your strategy because for anesthetic block or use an orthesis of the wrist, and you can see if the score change. If the score change, you validate your strategy. You perform you validate strategy, you perform surgery, and after it's possible to follow the patient with the score and the evolution. It's interesting because it's possible to follow the patient without see the patient directly, only with the score. And you can decide to have the revision. I see you an example with a woman. This is a stroke. She has a relatively limited proximal function, as you see on the diagram. The pronosupination is very efficient in this patient, you can see here. But wrist extension is possible, but there are problems. There are a retraction probably, and there are no thumb and finger extension, as you can see. You can see here, this is a problem. Initially, in this patient, we plan to evaluate with a median and ulnar nerve block to see what is the retraction, what is the function. After the test, you have the result, initial, and the result. It's interesting because you can see we wake up wrist extension, limited, but we wake up it. It is them for the finger and thumb extension. In this patient, we plan to perform partial neurotomy or FDS, FDP2, and polysystem and a long flexor polysys, but we perform too a lengthening tenotomy because we think there are retraction. You can see the result. The patient now, before is happy, now is not happy. I don't know why. You can see the result with improvement of a proximal function. It's interesting because we treat the wrist and we improve the proximal function. You can see the result on the radar. We have a very interesting improvement in this patient. She conserves the pronosupination, and you can see on the hand, before we haven't any grasp, and in this case, we wake up thumb extension, wrist extension. And in this case, the INOM score increased 72%, and the house score grade initially is 3, now is 5. You can see it's possible for her to take a pen. Okay. This is a first case where the INOM score permits us to build the strategies. You can see another case. This is a young patient with a good function, good proximal function. As you can see here, you can see the diagram. There are problems with wrist extension, is difficult because there are a spasticity of the flexor, wrist flexor and finger flexor. You can see. Okay. We perform a preoperative test with anesthetic block, and you want it. You can see the proximal function. Okay, very good proximal function. Proximal function for us is a very good prognostic factor. When you have people with very flex with a good proximal function, there are a big potential often. After the block, you can see that you improve considerably. There are a very big improvement of the patient. The house score from 5 go to 7, and the INOM score on 90%. We perform neurotomy. We perform a neurotomy of FDS, FCR, FDP, pronator teres with initial very good result. As you can see, 100% is not a normal end, but we improve this patient. We see the patient 6 more later, and bad luck, we not a recurrence of the spasticity. If you make the evaluation now, you note that we come back at the initial position. You can see the patient, in this case, the INOM score is 75%, half score degrees, and in this patient, we decide with the follow-up to perform a lengthening of the flexor, as you can see, and you can see the patient at the final evaluation. We come back to the initial position, initial evaluation, just after the denervation. You can see the sample size is not a normal end, but if we consider a normal end, any score is interesting. It's like when you use a KIF for a high-level tetraplegic patient, any evaluation is correct. In conclusion, for us, INOM score is an interesting tool for the spastic patient because it's based on analytic function and attitude vicious attitude being potentially cured by the surgery or medical treatment as the toxin or orthosis. It's not only for the surgeon, it's a tool that you can use when you use toxin injection. It's sensible and adapted to limited function of spastic patient. We don't work with pianists. In better case, he can play to clarion or but horn. But he's not a pianist. No, it's the aim of the surgery. This score is correlated with a prehension. Is a very helpful tool to build the surgical strategy to know what is necessary to do. We are going to now we make the validation because the problem for us is to know if in enter observer we measure all the time the same parameter, but I think it will be for us in a good tool. Thank you very much for your attention. Sorry.